Hi, my name is Liz O'Riordan, and I'm a consultant breast surgeon who works at Ipswich. And I've spent my entire medical career striving to provide a high-quality care for my patients. But what does high-quality care actually mean? When I think of high-quality care as a doctor, I now know can be very different to what a patient thinks. Let me give you an example. As a new consultant, I came across my first patient who needed a breast reconstruction, and I was excited but terrified. It would be the first one I'd do myself, without someone holding my hand and telling me what to do. I took my time, I double-checked everything. And when I saw her 4 months later, I was delighted. She looked fantastic. You could hardly see the scar. It was a great match for the other side, and I was just beaming. But her face told a different story. She hated it. And that's because I'd forgotten to tell her that your breast skin is numb after a reconstruction, that she'd never feel her husband stroke her breast. She thought it would feel the same. I had done a high-quality operation, but she had had an awful experience. So how do you measure quality of healthcare? Well, it actually has 3 parts. And the first 2 are really easy to measure. They're clinical effectiveness and safety. As a surgeon, I can easily check my own outcomes, recurrence rates, complications. I can benchmark them against my peers and confidently say that I know I'm providing a high-quality service. But when it comes to the third part, the patient experience, how do you know whether what they're saying is actually true? And that's where this comes in. A tin of Quality Street. Who can remember the first time they saw one of these? In my house, Christmas didn't start until we opened them. And for most of us that first time, it's that fear, curiosity. Ooh, they smell nice. What do they taste like? What's the orange one? Will I like it? And that's the same for most patients going into hospital for the first time. They don't know what to expect, but most people are happy. They're okay. It's nothing to write home about, but they got what they wanted. Back to the chocolates. In my house, it was these, the big purple ones, that went first. Everybody wanted them. I'd get really pissed off if my brother had 3 and I only had 1. And these are the patients that represent the patients who've had a great experience. Whether it's a nurse sitting with them for 20 minutes in the middle of the night to hold their hand, whether it's having an operation 2 weeks after they saw the surgeon. They're the ones who write you thank you letters and give you flowers, and they just make your heart sing. However, there's always another side to the story. And in my house, it was these, the toffee pennies, that nobody wanted. They stuck to your teeth, they took forever to chew, and they were left, sad and lonely, at the bottom of the tin. These represent the patients who have a bad time and want you to know about it. They're the ones who write a 30-page letter to your chief exec, and it kills you inside. None of us set out to harm people. And most doctors like me, you feel a gut reaction to change your entire practice based on that one letter, forgetting all the other people who've actually had an okay time. So how do you know who to listen to? Do you listen to the doctors who think they've done a good job, but they don't know all the patients who've had a bad time, but those patients don't want to speak up. They don't want to bother the doctor. They just want to move on with their life. Or do you listen to the patients who actually may have had a fantastic experience, but life moves on and they forget to send a thank you card? How do you know which are the sweets you need to eat and which are the sweets you need to leave behind? And that's where I come in. Because in July 2015, I was diagnosed with breast cancer myself. At the age of 40, I started chemo within a week. And I went through every test and treatment I gave my patients. And it's bloody hard, let me tell you. And I wouldn't be here today if it wasn't for the love and support of my amazing husband, Dermot, who's in the audience this evening. And he's also a consultant surgeon. And having gone through my experience together, we've both taken the time to reflect on how we now treat patients. And I'd like to share some of those thoughts with you today. So because I'm a surgeon, let's start with surgery. This is me taking the obligatory smiling photograph before I'm about to have my left breast cut off. And surgery was really hard for me because I'm a surgeon, and the person operating on me was a close friend and a mentor and a trainee. I had to bite my nails not to tell her, can you do this and put the scar there and use these sutures and let her do her job. But that's a whole other story. I've seen thousands of patients have operations. I'd never had one myself. I was scared and anxious because I know what happens when you go to sleep. Maybe that's why I was anxious. But what I didn't realize was having a general anesthetic is actually really painful. The last thing I remember before I went to sleep was crying out in pain as a burning sensation went up my arm. And I started speaking to some anaesthetists on Twitter who said 60% of people find having an anesthetic painful, and they now use local anesthetic to reduce the burning sensation. Little things matter. Now, as you can see, I look a little different now than I did then. I've lost all the hair on my head. I've lost my eyebrows, and I have 3 eyelashes that I'm hanging on to with all my life. Now, I know when you have an operation that we put tape over your eyes to stop them drying out when you have surgery. And I didn't want my eyelashes to come off when the tape is ripped off at the end. So I spoke to my anaesthetist and said, could you put a bit of gauze underneath the tape so I'll hang on to my eyelashes? And she listened to me, and she did, and I woke up with all 3 eyelashes intact. Lots of people have surgery after chemotherapy, but how many theatre staff know how important these little things like eyelashes are? We should take the care to remove the tape gently, but often we're in a hurry, we're not thinking, it's ripped off. What if every patient had gauze put underneath the tape? Think how many eyelashes we could save. The next thing I want to talk about is spending a night in hospital. I got an infection during chemotherapy. I had a temperature, and that could potentially be life-threatening. And it means do not pass go, do not collect £200, go straight to A&E for antibiotics within the hour. That's fine. There was a tiny problem. It was 10 o'clock on a Friday night. It was a bank holiday weekend, and it was payday. A&E is the one place you do not want to be, believe me. And I could have gone up and said, I'm a consultant surgeon, and my husband's a consultant surgeon, and ex-medical director, and locum chief exec. We're not a normal couple. I want to be seen now. But I didn't, because I wanted to find out what it's really like to be a patient. And the care I had at West Suffolk was fantastic. Within 40 minutes, I'd been triaged by a nurse and had antibiotics going through a drip. And they decided to keep me in overnight. And that's when I realized that an acute general medical ward is the last place you want to be when you're sick, and it's the place we send our sickest patients. And that's because you do not get any sleep on a busy medical ward. And there are 2 reasons. The first is the bing, bing, bong, bong, bing, bing, bong, bong of all the fluid pumps that are going off out of time all over the ward. It drives you crazy. You know the nurses can't come because there's 2 of them looking after 40 patients. But as a patient, you don't know whether your bing-bonging pump has to be seen immediately or whether it can wait half an hour to be changed. The other reason you don't get much sleep on a medical ward is the patients. There's always people coming and going through the night as they're moved into beds, and some patients are noisier than others. The night I was admitted, at 2 o'clock in the morning, there was a little old man at one end of the ward, and he suddenly started shouting, "Help me! Help me! Help me!" Silence. Then, on the other side of the ward, a little old lady would reply back, "You're a horrid man." He would reply, "Well, you're a horrid woman." And then silence. And you'd just get off to sleep when 5 minutes it would start up again, all through the night. And then your consultant comes to see you bright and early at 8 o'clock in the morning, having had their caffeine hit, asking you all these questions, and you just want to tell them to F off and leave you alone so you can go back to sleep. The one place I've done most reflecting, though, is in outpatients, because that's where I spend most of my time as a surgeon. And this is me waiting to see my oncologist before my last chemo session. I don't look very happy. Now, most oncology clinics run late because patients have a lot of problems and it takes time. This particular session was unusual. We were running 2 hours late, and it was all my husband's fault. He was the chief clinical information officer, and the hospital had just gone paperless. And it was taking the doctors and nurses much longer than usual to get their heads around the new computer system. And it was quite funny because the clinic nurses would come out and offer us cups of tea and say, "We're really sorry we're running late, it's all my husband's fault," without realizing he was sat next to me. But I'd gone into that appointment with a long list of questions to ask, and having waited for 2 hours, I just wanted to get in and out and get home as quickly as possible. I didn't ask any of them. Now, I know how to find the answers, but what about all those other patients who leave their clinic appointments with all these questions unanswered, feeling they don't have the time to ask their doctors? What happens if they get wrong answers from the family and friends they do speak to? Now, a couple of years ago, I had to give a patient results that she'd had a second skin recurrence in her chest wall following a mastectomy. And I went into the room, and before I could sit down and say, "Hello, my name is," she said, "It's cancer, isn't it?" What? How on earth do you know what I'm going to say? And she said, "It's because you brought the breast care nurse with you. When it's good results, you come by yourself." And she's right, but I never noticed it. Now, when I saw my ultrasound, I knew I had cancer. I didn't need the biopsy results to tell me. But when my husband and I were sat waiting, I said, "Just watch. If the breast care nurse comes to call us through, instead of a clinic nurse, it's cancer." And he didn't believe me. But sure enough, the breast care nurse came to call us through. A friend of mine had a slightly different experience. While she was waiting to get her results, she realized that the doctors were using 2 rooms. Let's call them Room A and Room B. Everyone going into Room A came out smiling. Everyone going into Room B came out looking like their world had ended. She was called into Room B. Now, it may not be a bad thing to give patients forewarning they're about to hear cancer, but is that really the way we want them to find out? It's hard with breast cancer because you have no symptoms. You feel so well, it's hard to believe it's true. But what's far worse than knowing you're about to find out you have cancer is when you have to leave that clinic room, holding on to your tears, walking past a waiting room full of people, past the nurses and the receptionists, and all the other people you meet in the hospital corridor until you finally get outside to a bit of privacy where you can howl and shout and swear at how crap life can be. Wouldn't it be great if every clinic had a backdoor escape route to a secluded garden area where you could just sit and compose yourself in private before you went home? The final thing I want to talk about is language, and I think that's where my husband and I have both changed what we do. I can break bad news 10 times a day, and it's really hard to do it as well in the beginning of the day as I do at the end. But until you've been on the receiving end and you've had bad news broken to you, you have no idea how you come across. And before, I used to tell patients, "You're lucky we've caught it early, and it's really good it hasn't spread," because I've looked after women with metastatic cancer, and it's not nice. But when you're the patient, those little words, such as lucky and good, take on a completely different meaning. No one is lucky to have cancer. No cancer is good to have. And it doesn't stop there. It goes with when we consent people for operations and procedures. When I'm talking to a woman about a mastectomy and I've gone through the pros and cons, I then describe the list of complications: infection, bleeding, further surgery, chronic pain and numbness. And after all of that, I say, "If you're happy to go ahead, can you sign the form?" What patient in their right mind is happy to have cancer? Happy to sign a form saying, "I might get a complication that's permanent and can't be treated"? The words we use can have a dramatic impact on the patient experience, but we can't hear them because we've never sat in our patient's shoes. And that's why the work of this institute is going to be so powerful, to collect the evidence and data to prove that the patient experience does matter and use it to improve healthcare for everybody. An American cardiologist, Eric Topol, in his book, The Patient Will See You Now, said that the patient is the single most unused resource in healthcare. Patients are the driving force who are going to produce change in the future. We know what we want, we know what we need. We just need people to listen to us. Whatever your reason for coming this evening, I want you to remember why the work that this Institute will do is so important. It's because you will all be patients yourselves one day. Thank you.